Sarah Lavonne, and I'm so glad you're here. Here at Bundlebirth, we believe that your life has the potential to make a deep, meaningful impact on the world around you. You, as a nurse, have the ability to add value to every person and patient you touch. We want to inspire you with the resources, education, and stories to support you to live your absolute best life, both in and outside of work. But don't expect perfection over here. We're just here to have some conversations about anything birth, work, and life, trying to add some happy to your hour as we all grow together. By nurses, for nurses, this is Happy Hour with Bundlebirth Nurses. Welcome back to Happy Hour with Bundlebirth Nurses. I have Morgan here, and if you have not listened to episode 1 of this now series, please pause this episode and go back to episode 1 because we are literally picking up exactly where we left off with that episode, specifically talking about near fatal strangulation. And right now we are getting into the nursing assessment side even more so. And so the resource that you just heard about is a resource that is in your show notes down below. You can check it out yourself, download it, bring it to your unit, have it in your resources list wherever you keep the resources that you're referencing on the regular, as we all continue to be better and continue to be, I'm going to say, more thoughtful, more thorough, more equipped nurses. Yes. In our specialty, in ways that maybe when you got into nursing, you never thought that you would actually have to be. And so we left off our last conversation specifically talking about what we as nurses may recognize at the bedside in the case of a near fatal strangulation. So you talked about some of those like physical symptoms, and you can reference the resource down below. And that, to be honest, like the pictures and all that is like so helpful for my brain as well. So you can reference that. Some of the other things that you mentioned as far as just things that they would say potentially. Is there anything else that you want nurses to know about the signs that we are looking for as nurses?
Again, sometimes they are very subtle. They are very subtle. Sometimes it's in their hair, sometimes it's behind their ears. But if they have shared with you anything that has happened, right? If something looks off, our assessment skills are so important. And it's the follow-up question, right? Because we're not going to assume. We never assume, right? So sometimes, again, you build that rapport and you look down like, hey, girl, what happened to that nail? And if you immediately see them do, like they put their head down, they don't want to talk about it. They may, I broke it on something. Like, oh, girl, how'd you break it? Find out. It might be just as simple as, I was trying to open a can, and then it might be something more, The other thing is trying to connect with them and ask those questions, because sometimes we don't want the answer. We don't want to know. And it's probably because I don't want to know because I don't know how to help. And if I know now I got to do something about it, right? And I know that mandatory reporting can be scary. I know all these things can be scary. I'm not asking labor and delivery nurses to be forensic nurses. All I'm asking is that when they come in, you do your intimate partner violence screening. Do it right. Do it right, please. I know it can be hard, and we're going to talk more about how to do it right. And if your spidey senses are tingling, let's escalate. Let's bring in a forensic nurse. Let's do a thing.
So speaking of spidey sense, based on last episode, we learned that 1 in 4 women experience domestic violence in their lifetime.
Yes.
Right? And we know that the instance goes up in pregnancy.
Yes.
And so when we're asking those questions, it's easy to blow over and be like, oh, well, there's no way. No chance. It's ignorance is bliss, denial, call it whatever it is. But the reality is that 1 in 4 at some point in their life, whether they're experiencing it actively with their current partner or not, have experienced domestic violence. And so talk me through, you as a forensic nurse and as somebody who specializes in this, what are your suggestions for us / what do you do? Talk me through how you approach the questions in our intake. Which are, do you feel safe at home? Like, and they're like, they to me, it's almost like I feel awkward, to be honest, for one. And I feel like, oh, no one's going to tell me this.
Right. So the first thing, again, your assessment skills using your eyes, right? Look at your patient, look at their demeanor, how they're holding themselves. Now, if she's, 9 centimeters and doing the things and we're
Sure.
about to rocket out a baby, this is
Right.
not the time for this, right?
Yeah.
But what's going on? What's happening in the moment? If they're coming in or if they're with me and something feels off or just in general, like with everyone, because I'm going to ask everyone this question. I if the other partner is carrying the bags, right, I might get mom into the room and like, walk her to the bathroom and be like, here's the cup that I need you to pee in and here's a gown. And hey, I just want to ask with like a very soft voice. And I ask everyone, and I'm going to use my normal voice because obviously we're recording, but
Right.
do you feel safe at home? Is everything okay? And I'm like, and if they'll look me in the eye, and I've had someone shake their head like no before. And I said, okay, go ahead and just pee in the cup and change for me. And what I ended up doing is, so she's now safely in there. And I was like, thank you so much for bringing the bags in. And you can put stuff here. I've got to get the doctor and we've got to do some stuff with mom. It's going to be boring. And on top of that, just kind of getting her settled. Why don't you go ahead and head down and you send them to the cafeteria? It's all about them. It's going to be boring stuff. We got to get her all checked in, hook her up. She's not going to be able to walk around. And I try to get that person out of the room. If that doesn't work, most units have either an ultrasound room or a triage space or like a separate space where you can make an excuse like, hey, we're just going to take mom down the hall, run a quick test, run a thing, do a thing. You know, we can't, I'm
Mm.
sorry, the room's not big enough. Like, the space is not big enough. So just hang here. She'll take her phone. She'll take her phone. You'll be fine. And then I'll separate them like that.
And
So
I'm the partner, and I'm like, no, I have to go.
I understand that you want to go. It's exciting. We're having a baby. This is exciting. I just can't take you down there. I'm sorry. Like they're not going to let me take someone and I have had someone insist and then we get to the space and they have to stay outside the room. Like you
Mm.
literally take them into like an area and then they're separate because the answer is no. I'm sorry.
Right.
And I mean, if it escalates beyond that, then I already know as a nurse caring for this patient that my safety is going to be
Sure.
in
And like
question.
something's going on, clearly. Like
Yes.
you've been slightly confirmed, you know?
Yes. So if we get to that
Hmm.
point where you're already trying to push against me, and again, I'm very mindful of the other person. I don't know what's going on. But hey, real simple. It's normal in hospitals for us to need to separate our patient to do an ultrasound, do a scan, do a something. Not
Hmm.
everyone can come with you and hold your hand 24/7.
Hmm.
And I remind the partner, we're going to take the phone. She's got her phone. You've got access to her the whole time. I'm sure you're going to watch the tracking dot as I move her through the hospital.
Right.
It'll be fine, you know. But you try to keep everyone calm and you let them know as soon as you can have her back, you will have her back. I'll also share with you, there is a recommendation for specifically a pregnant adult patient that has experienced non-fatal strangulation. So we can give that to your viewers. That comes from the Training Institute. And it's like essentially the Dear Doctor letter or the what happens when they present to the emergency department. So if they come through like an office, like if any of your nurses work in an OB office versus in the hospital, this is
Hmm.
what you would give them. And a lot of times, what we do at the sexual assault center, at the center, is I will take this sheet and I will circle the things that I personally have assessed on my patient. So if it was, petechiae or swelling or voice changes, or I circle all the things so that and I give them a paper copy of it when they get to the hospital and they're like, I need at the ER this CTA, this thing. I've made sure that so the patient doesn't have to remember any of that. If they
Yeah.
just come with this,
Hmm.
you know. And it's the same now if you work in the hospital and you're doing this, the moment I've identified these things. So this is still a good resource to have in the hospital. The only difference is you're not sending them to the emergency room. They're already there with you. I would then be calling my provider and I would be pulling this up going, hey, my patient, and you can start showing them these are all the symptoms and the signs and things that point to, based on evidence-based resources, this is how we should be caring for her
Mm-hmm.
while she's pregnant. Because I know as soon as we start talking about CTs and radiation and pregnancy, everybody
Right.
gets like,
What do you mean? Well, and
yep.
I'm like, are doctors trained on this? Like, is this a part of their standard training that they would have a walkthrough of what to do? I'm like,
Not,
literally, I've never heard of any. Like, this
not
is
really.
what?
I think so. It's mentioned, right? Like, so at some point they talk about trauma when they're in doctor school, when they're in medical
Mm-hmm.
school, when they're becoming the doctor, right?
Yeah,
Once they specialize, so an OB, because we're talking to labor nurses right
sure.
now. So where I'm going with this is in the emergency room. Think about how many people have tried to hang themselves
Yeah,
or
yeah,
have, been in a car accident where like, the seatbelt got around their neck or this or that.
sure.
These are all other forms of strangulation. So those doctors tend to know how to deal with those injuries a little bit more because they see it in trauma, right? Think
Yes.
about little kids being clotheslined or this or that, or their clothes getting
Mm-hmm.
around their necks. Like, so pediatric ER doctors, they're going to have, but it's because they see the same kind of injury in different ways.
Yeah,
But how often are we sitting down with the obstetric doctor going, hey, your patient population is at the highest risk of this, and the number one manner of death is homicide, and da 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 da, and here you go.
yeah,
So no, I think we've missed that piece, but I think it's because when we first started getting these little crumbs and started realizing, like, and we followed the path, right, and we realized what's happening. Now we're going, okay, this is how we start solving this problem, and the first step is disseminating this evidence-based research, and bring awareness. We talked about in nursing school, the levels of prevention, disease prevention, right? We're
mm,
in level 3 where we already have the disease and we're managing it. This is a disease our society already has, and we're learning how to manage it.
yeah,
um but the I want to get into better screening and better
mm-hmm.
awareness so that we're not all I want to do less of these where I'm recognizing signs and symptoms, and more we're doing early screenings. And before we get to the strangulation part, we've already got the safety plans in place and we're doing better identification of problems
Yep,
and supporting these women out of these situations.
yep,
Um, but there are tools, there are things, and I want these things for every hospital, every nurse, at least to know where to access them.
yep. So they come in triage, I'm almost like thinking, because again, my systems
Uh-huh.
brain goes crazy and I'm like, okay, like a culture change. And this is like a workflow change too, especially those of you in triage. You
Hmm.
are like, hello, this should be like red alert, like all the
Yes.
resources downloaded, and start having these
Yes.
conversations on your units of like, what are we going to do and like pull the policy. And there might not be anything actually. And if there is, there needs to be. And so,
So,
it's almost
yeah.
like, but I think about one of my, okay, so my very first hospital, it was like a big room with a bunch of triage beds that had curtains.
Hmm.
And when I first got there, we would keep the partner outside for the triage assessment.
Yeah.
Like they were alone in triage. And so from this vantage point, I'm like, that's fabulous. That's great. You get them alone, you build rapport, you can kind of ease your way into the questions. Cause I'm like, how awkward. You're like, here, pee in a cup. Do you feel safe at home? And it's sort of like, which I want you to address as far as like, just, I like the whole, like, I ask everybody this. And while I have you alone, I would, I would love to know and make sure that you feel safe at home, or
Yes.
whatever. But also like in my head, and I'm writing story here, which I should not, and I need to hold back so that I'm not like
Hmm.
making assumptions that no one's going to disclose. But I'm like, I literally just met you, lady. Like you're going to ask me and I'm going to disclose to you that I feel unsafe at home. And unless it's like they've been thinking about getting out and they're there to get help and they want someone to ask those questions so that it opens up the door, Maybe, and we need to give that benefit of the doubt, but otherwise it's so incredibly awkward. And so when I think about triage, I'm like, get them alone. Great. Start the assessment always alone. That in theory could be a quick fix. And you also have 3/4 of the population that will never experience this. And it's labor and birth, and they want to be with their partner. And like me as the doula, I'm like, don't kick me out. She needs support, and as a doula whom like I know that their situation is safe. So how do we navigate that? Like, what's your suggestion for us? I was thinking back to when I was a brand new nurse. I'd have these patients who would just not progress. No matter what I tried, they were stuck. I finally would go on break, and that one experienced nurse, you know which one it is, took over for my break. And by the time I came back, the patient was complete, which is amazing, yes. And I'm so grateful for them. And it was also so frustrating to feel that helpless, to not know what to do, and then ask, what did you do? And they actually can't tell you. If you know me at all, you know that I get obsessed and cannot stop until I find all the answers. And this one got my brain going. I wanted to figure out what the heck so many of our experienced nurses were doing, and more importantly, to finally understand the body in a way that we are never taught. I wondered if there were things I was doing that could either help or hinder the labor process. And by the way, I learned there is. I wanted to equip myself with tools I could use with my hands tied at the bedside, well, both as an L&D nurse, but especially now when I'm attending births as a birth coach and my hands are tied. I'm not able to titrate the pit. I'm not able to call the doc for interventions, and I'm relying fully on the physiology of the body to help labor work. And after reading hundreds, if not thousands of resources out there and putting in thousands of hours of work, I figured it out. And I want to give you that too. If you've ever felt helpless, hopeless, or alone in your practice, you are not the only one. More than 7,000 nurses have now taken our physiologic birth class, and they describe feeling energized, empowered, and equipped for their very next shift. They walk away with practical, repeatable tools they can use with every patient. Not a one-size-fits-all prescription approach, but the ability to critically think your way through any birth scenario. A way to look at the body and know exactly where to start. You can activate physiology and optimize the systems that actually make labor work. Together, we can change the game in obstetrics. So if you're ready to feel confident instead of stuck, equipped instead of overwhelmed, and connected to a community that is committed to excellence, knowing that you're not alone, join me at our next physiologic birth class. It's truly a masterclass for every nurse to apply with every patient. Link is in the description. I can't wait to see you there.
Okay, so from my own research, my nurses responded to me. Thank you to all the nurses that participated in my dissertation research. 58.47% of them said, my unit does not have a protocol for this, for near fatal strangulation. Okay, so that's a lot. And then 34.43% said, I don't know. I don't know. Like, does it exist? Does it not exist? I don't know. However, 2% of you said yes, and I'm familiar with it. And the 4% were like, yeah, it exists, but hey, I'm not familiar with it.
That's so interesting.
Yeah. So, that being said, there's 58% out there. We have got to get you guys some protocols. Okay.
Yep.
Even if they're not used as often as you need, we need them there. All right. I think nurses, and especially our newer generation of nurses, while I don't want them to be task driven, they do well with, checklists, with protocols, with tasks, and
in something
having
like this,
a policy.
I need a checklist and I need a policy because unless I'm going to go become a forensic nurse that specializes in all this, I need support.
So again, they're coming into you, whether it's to have a baby, seek help for a problem in their pregnancy, whatever the case may be. Again, separating them, asking and building rapport. So before I even get to that question, right? So a lot of times it's the transition to the room. My name is Morgan. How are you? Oh, are you from here? Tell me, are you have a little boy or a little girl? Start talking, asking them about them. Oh, that's so exciting. have you had a chance, like if they're early in their pregnancy, have you already had a chance to paint the room and do the things? No, no. Oh, okay. I get it. I'm busy too. Start connecting with them, however you do it, so that by the time you've made it to the room or whatever you're doing, right? Because you've already shown genuine interest. And it's not that you're not genuinely interested, but show your patient that you are genuinely interested in who they are. They're like, tell me about the name you picked. Well, how did you come up with that? That's such a great name. Wow, I love that. Because you're showing them in little ways that you're hearing them, asking why they picked the name or how they came up with that. They're heard, you're paying attention. So you're not just
Mm-hmm.
asking questions to make small talk. You are hearing them, you're validating what they're saying.
Yep.
If they're talking, maybe they're there for a problem, right? And you're like, oh, I am so sorry that you're experiencing this. We're going to figure out some way to get you some comfort, or we're going to figure out like how to alleviate some of these symptoms, whatever it is, showing that like I hear you, and dude, those symptoms suck, because then they
Mm-hmm.
they start connecting with you because she heard me. So then when you have that moment, and like I said, sometimes it's as simple as just walking them to the bathroom to get the urine sample or something, just to start the induction or to start the whatever we're doing.
Yeah.
And you just very quietly, very quickly, and I always look them in the face. I look them in the face and I look them in the eyes, and I'm very like soft. I learned something at Move and I still do it. And now I teach it to people. And it is, I stop at the door and I take a deep breath. I
Mm-hmm.
pause at the door and I take a deep breath and I settle myself before I go in, because all of the things I carry, all of my emotions, my feelings, I'm going to transfer that into this person.
Mm-hmm.
And so I need to, release anything bad, release all my assumptions, and come in there with open arms, right? And an open heart, so that when I'm looking at her in that moment, my face, my body language, it's not rushed, it's not tense. It is
Mm.
nothing but pure care and empathy and love in that moment, and that one question. And that's all it is. It's one question.
Yeah.
And it really depends on your tone and how you present it. And like I said, it makes such a big difference in your practice. Or like you let them go in the room, you get to the door, you kind of hold your hand out, and the patient's walking into the room. And I take my deep breath, and then I
Mm.
come in and we start the process.
I remember that episode, by the way, because it was a
Mhm.
podcast episode. We'll link that down below. It's like we reference it in almost every episode and everything we do. And I remember talking to Justine and being like, this is such a simple practice that would make the biggest difference in what we do on all
It does.
fronts, on
Hmm.
safety, on judgment, on all the respectful all of it. So it's like so heartwarming to me to hear, and also like the reflections from the Live Colorfully class, or like everyone was
Hmm.
reflecting on pause at the door, which I think is so cool. Now there's a class on it. So anyway, continue. It's so nice.
No, I just, but if you can connect, right? Like that's what we do. And
Yeah.
if you get the answer, right? If you get the no, or if you get the yeah, I yeah, but you can tell they're really struggling to get it out, right? And you go,
Yeah.
okay, just give me the urine sample, do the thing, smile, and then, you know, escalate per policy, right? Don't
Mm,
ask questions, don't put them on the spot in front of that person, right? Do the things that you need to do. Okay. We're not there to ruin the experience of having a
sure.
baby or whatever they're there to do. Okay.
Yep.
But you as the nurse know, like we have a problem, we have something, right? And we are going to look for the appropriate time to ask questions to get into some of these resources. Sometimes it might be that the partner has left to go get food or whatever. You've already glanced at the material and you've got just a little window to ask some more probing questions, right? Think about if it was anything else, like, oh, you've got this wound on your foot. How did you get this wound? Did you trip? Did you fall? Did you step on something? Does it hurt when I touch it? Does it
Mm-hmm.
have it, is it warm? Does it blanch? Does it this? This is the same concept. The only difference is that they're questions, because I'm asking about hurt that I can't see necessarily.
That's an interesting frame that I don't know that I've ever thought about. Is like the do you feel safe at home question is the screener, and then you get a oh yeah, I feel great at home. You move on, but you get a hesitant yes, you get a no, you get a something in between where there's more to explore. That then that's when you create an environment and or you watch for a
Hmm.
moment that then
Yep.
you can ask more questions and provide the opportunity to open up that conversation.
I tell my patients often I am like the cruise director of their labor, but the baby steers the ship. So, as a cruise director, I can curate moments at times, and I will look to curate that moment where I can have some alone time with my patient, right? Just like, we can do different things with, peanut balls or birth balls or
Mhm.
different things, and we ebb and flow, right? And
Mhm.
I'm gonna use my skills, the things that I've learned. I'm gonna read the room emotionally, and I'm gonna find the right time, and I'm gonna create that moment if I can.
Mhm.
And it might come later, as long as we're safe in the moment. Safety in the moment is paramount, right?
Sure.
But
And
once
like
I've
whatever's
identified there's
going
a
on and how
problem,
they present. Yeah. And if it's
yes.
labor, it's going to be much less likely to be like
Mm-hmm.
the primary concern.
Yep, because
Yeah.
that imminent birth, that labor is priority. Remember, as nurses, we prioritize, but I can't let her go home unchecked. And so
Sure.
let's say you're the nurse that's leaving, right? You're the nurse that's coming off. All right.
Mm.
And you have had I don't know, with the screening and the things. In my report to my next nurse, I'm going to be, hey, this is what I've documented. I'm going to put a nursing note in. Safety questions asked. Patient hesitantly gave a yes. At this time, my nursing priority, safe. We are safe in the room. However, delivery is imminent. So I would place a care consult. I would also notify the OB. And then I would also go ahead and see what other resources you have. Because once the baby is here, like once the baby has been born, and we are now in that less urgent, because that delivery is definitely a health priority, because that's coming
Mhm.
and I'm not stopping that. The other thing is, I don't want to change her hormones by asking these questions,
Mm.
because that
Good point.
will affect her labor.
Yep.
Okay. So when I see in my patient's chart that she has suffered a sexual assault, I don't tend to bring that up. But what I will bring up is there anything that I can do to make these checks more comfortable? Are there things that I can do to make this a better experience for you? And usually when you say like checks and stuff, they're like, "Oh, okay, yeah, yeah." And they know without actually saying, "Oh, because you experienced sexual assault because of this."
Right.
Like, I don't
Right.
even want to say that word while they're there.
Yeah. For
you
labor
know yes,
specifically.
for
Mhm.
labor, because
Yep.
specifically I am like, when they are in labor, this baby is imminent, it is coming. I am very mindful of the physiological process and the hormones and the
Mhm.
things, but I'm not going to forget, and I'm not going to let them fall through the cracks, because I need to make sure. And I know sometimes like I might not be there at the delivery, so I'm going to make sure all the other things are in place, so that when I step away, I'm telling in my S bar to my next nurse,
Yeah.
I have done these things, and I need in the next S bar to the next nurse, we need care consult. Let's get a forensic nurse. Let's get a thing. Because it's okay. It's not our wheelhouse. But
Yeah.
let's make sure before she leaves, one comes up here.
Yeah. Somebody sits and talks with her.
Exactly. And there
Yep.
there are advocates in the hospitals. Almost every hospital should have advocates.
And it wouldn't be necessarily OB specific. It would be a forensic nurse from like another unit, correct? Unless you have somebody like
So
you.
some hospitals do have forensic nurses. So I'm over here in Georgia. So for example, Grady actually keeps sexual assault forensic nurses on staff. Not every
Smart.
hospital does. A lot of
Mhm.
children's hospitals do. But
Mhm.
if they don't, guess what? Your ER at some point has dealt with this. And there is, when I say this, a sexual assault patient, somebody's come in and said, this has happened to me. And they're going to have a protocol on how to get a nurse or someone who does this.
Yeah.
So if you're in labor and delivery and you're like, okay, I have it, here it is, or this needs a better interview,
Mhm.
it needs something more, call the ER, find out what your protocol is. And if they don't know, there's going to be a non emergent line. Almost every police station, whatnot, where you would do your mandatory reporting, they've got a protocol and access to a forensic nurse.
And your mandatory reporting is
If you have a patient that's experienced a violent crime, gunshots, the strangulation is a violent crime, if they've been hit, assaulted, anything like that. At 16, we have age of consent. So if you have a 16-year-old that comes in and has a baby, I remind all of my nurses, you have to do the math. Was she 15 when she conceived? Because if she was 15, she couldn't consent. And
okay.
you have to report. Now you'll go looking through their chart and make sure somebody, if mandatory reporting has already taken place, it only has to happen once, but there should be a clear note in the chart with a case number that it's been reported so that they're not getting a call every time this minor comes into triage.
Mm-hmm.
So,
Oofda. I'm like, whoa, our whole nursing practice just opened up a whole lot of things, like cranial nerves. I'm like, I haven't
yeah,
done a cranial nerve assessment since nursing school practically. Oh my
right. But
gosh.
if someone comes in and they've got slurred speech and
Right.
you're thinking they're drunk or high, like, but they're like,
Sure.
no, no, like I'm not, like, what do you do? Right.
Yeah.
So, this is how,
Yep.
and a
Yeah.
strangulation assessment. And this is like truly like, if you can't get a hold of a forensic nurse, or if something's going on, that's what these resources are for. And the thing is, as a nurse, we learned all of this in nursing school. You
Yeah.
learned every bit of
Totally.
this.
Yeah, that's
It's
what I'm
just a matter.
referencing as I'm like asking you these. I'm like thinking back to my like
Yeah,
what was it, health assessment or whatever
yeah,
class, and I'm like, oh yeah, I was so good at that.
yeah. Yeah, you did every bit of it,
Yeah.
in nursing school. So this is not some crazy thing
Yeah.
that you just, are now having to figure out. Like, nope,
Yeah.
you
That's why we went
you
to
can do
nursing
it.
school. Yep.
Exactly.
How do you stay non-judgmental? Because I mean, I want to address, and then we're going to get into your research. I think
Okay.
there's, one of my dreams for us as nurses, and especially the bundle birth nurses community, you've heard me address it in a million different ways across all sorts of classes and podcasts and social media and all of that. But like, we can be a judgy bunch.
Yeah.
And especially how we speak, like you talk about nurses eating their young, but not even that, like workplace bullying
Mm-hmm.
is extremely prevalent. We all know that this happens. I've talked very openly about that it's happened at both of my facilities, and that it contributes to people leaving the profession, leaving their units. It contributes to high levels of stress and anxiety and allostatic
Yeah.
load and all the things for us. And so, I think for all of us to just pause for a second and think about the culture on your unit of how we talk about people. And it's talk about each other. It's talk about doctors. It's talk about our patients. It's talk about their patient scenarios. It's how we pass report. And, and then you think about society of just like, we talk openly or use the word stigma, right? That like we're so, don't be stigmatized for mental health or substance use or, domestic violence or sexual assault or whatever these like big issues are. And it's easy to say, don't stigmatize it. And yet we see it all the time subtly at the bedside or not. And so, I think I mentioned this last time. I think for me, one of the things that's been really helpful is this like come to Jesus of I do not and will never know what it's like to be in their shoes. And people will say, just put yourself in their shoes. And I'm just like, I kind of hate that phrase because I will never know. And I can empathize a lot and I try and I'm like, listen, and I apply myself, but I will genuinely never know what it's like to be in your shoes. And so that for me has been really helpful in my process of growing to be more curious, not judgmental, and and now teaching on this stuff in the Live Colorfully class particularly, but inner thread throughout all. And so when you've specialized in all this stuff, and in episode 3 we're going to come back and talk about the sane nursing side of things and forensic nursing as a whole. What are the tools that have helped you become so, and I feel it from you, I felt it from you from the start of just like this, like, I do not judge you. And like this lack of shaming each other, and especially as women, we are so hard on each other. And, you know, and we're especially judgy on each other because we say like, well, I would have never done that, you know, and yet again, like you don't know unless you've been there. And so, talk to me about that in particular. And if you have any suggestions and tools for how we continue to grow in this, because I want to say that like first thought, second thought, like there's some of it that's been just built into the culture as a
Mhm.
whole and culture on your potential unit, and it's so easy to get caught up in it, and the gossip and the again, for lack of a better word, judgment. So tell me.
It's hard at times. I'm not gonna lie, right? We're all human.
Mm-hmm.
Um, but here's the thing. I remember being a child and I was experiencing things that I was ashamed of because I was around people with loving parents and, happy, everything was great. And I felt shame and I couldn't talk about it. I was scared of being ridiculed or feeling different, right? So I never got help when I was a kid for this situation. And then now as an adult, I still carry shame around that, like talking about like childhood and the things that happened. And I'm like, you know what? No. Um, Whether it's, being cheated on by your husband, you're not alone. It Having a bad childhood, being hit, you're not alone.
Mm-hmm.
It doesn't make you a bad person. It doesn't make you less. It doesn't make you like, it made you who you are. And I'm here to listen and let you sometimes, people as adults still need to heal the child inside of them. And if in that moment you're ready to share a little tidbit or let it out and it's going to help you heal, let me have it,
Mm-hmm.
because I get it. I get it. And I am a human being and there are definitely times where I'm doing like a sexual assault case or something. I don't need to shame them because they're busy beating themselves up and shaming themselves
Yes.
more than enough. And
Yep.
they know they made a mistake and they don't need someone else to tell them they made a mistake. What they
Yep.
need is compassion. What they
Yep.
need is someone to go, I know
Yep.
the mistake is done, but how do we move
Yep.
forward? Let's
Yep.
be solution oriented.
Yep.
Yeah, no, there's definitely times that I look bad and I'm like, oh, what was she thinking?
Right.
Like,
Right.
ugh. But I don't tell her that, like I think about it to myself and that's a normal human reaction. And then I go, no, she was being a child. She
Yep.
was being a young woman. Her brain is not
Mm-hmm.
developing. Like, she was under the influence of alcohol, whatever the case may be. She was
Yep.
not making, and it doesn't make them a bad person for going out and having a drink or this and that. Like, we're all human beings. And until we
Mm-hmm.
start treating each other with that level of compassion, then we're never going to get better. If
Yeah.
I'm too scared to take the journey to heal because someone's going to judge me or shame me or ridicule me, then I can't heal. And then I can't be a better person in society. Then I can't
Mm-hmm.
produce better people, right? Like if you have
Yeah.
kids, sharing that, generational trauma and all the things. Like, no,
Mm-hmm.
I need to, I need to heal and I need to make space for those around me to feel safe to heal. Their problems and burdens are not my burdens. And I have to remember that at times. So there is a box that I put them
Mm-hmm.
in. So there's a lot of self care. I was talking to a friend about this the other day. I was like, I sleep, not an abnormal amount, but I sleep what my body needs. And that is honestly very important for my healing and the ability to do this. So, it might take me a little longer to get something done, a craft or a thing in the house or a project or whatever, because when it's time for bed, we go to bed.
Yeah.
When I'm tired, I sleep. So, listening to my body is definitely part of it. And not everybody is going to be responsive. If someone does share a judgmental thought or a thing, I remind them again, we frame everything positively. I hear you. I know that that's how you feel. However, this person is here now trying to heal. Let's support that.
That's good. It's simple and just to the point.
And it's not invalidating what they're saying or feeling because chances are they're right. Their feelings are
Yeah.
valid,
And it
but
is. Mm-hmm.
but we're not going to get anywhere with that.
Yes.
It's not going to fix our patient. It's not going to help our patient. It's not going to help you. It's not going to help society.
Mm-hmm.
You're
Mm-hmm.
allowed to think it in the moment, get it out. I let him get it out. And I'm like, okay, cool. Now let's go be nurses and fix it.
Yeah. Well, and I'm thinking about the nurses who are listening to this and they're like, "Ooh, this is a sexy new thing." And I just what my fear is that unless you are super duper self-aware of your motivation for maybe, asking the questions and getting the information, that like we all need to be extra self-aware that like we're
Yes.
not here to know the tea and have a good
Yeah.
story or to you
This
know
is usually tea you don't want. This is the dark tea.
somebody that I worked with, they like called me in to look at something and it was
Hmm.
like and I still have shame about this, that like she was like, come see, like, and just act like you're coming into whatever, like come see, oh my gosh. And
Hmm.
it was like a rampant STD, or STI.
Mm. Oh my
And
gosh.
yeah, but she was like, "Oh my god, it was like this, it was exploitation." And I was
Yeah.
like, "Oh, in my curiosity, of course, I was like, "Yeah, I want to see, like, come on." And she was there getting checked and like prepping for pushing, and I came in to literally look at this woman's vulva. This was year 1 as a nurse. I still am like, "Ew." Ew. And the medical side of me, I separated in that moment. I'm not like thinking it's like the
Yeah.
vagina component of it or the vulva part of it. Like we've seen a million. But also like I think back and I'm like, ooh, my curiosity about the story and about my learning and about like, wow, this really happens. Like some of this stuff, as dark as it is, it's also somewhat sexy if we want to call a spade a spade. And
I mean, it
so
is.
like what I want to just pull and like say, and then if you have anything to say and contribute, fine. But like
Yeah.
that, let's roll it back and let's be really, really mindful in these
Yeah.
scenarios that these are human beings and that we're not exploiting their story and coming to the nurse's station and going,
No.
ooh, I got tea. You want to hear about this one? She doesn't feel safe at home. Like, or she was strangled, y'all. She was strangled, like,
Yeah.
whoa, whoa, whoa.
If and here's the other thing. Sometimes as nurses, when we're doing this, there's a reason we have advocates. Okay. So if you need to ask questions or if you want to have these questions asked, if sometimes like when people are coming into the hospital, we'll tag team, like one person's putting on monitors and one person's asking questions, and right.
Mm-hmm.
So if you have two nurses that have some already established FaceTime, and you don't want to go in alone to ask questions, right? Maybe you as the nurse do want a buddy system feels safe, right? So we're not
Mm-hmm.
talking about exploitation, we're talking buddy
Yeah, yeah.
system for hey, I brought so and so, they were here with me earlier. We want to ask some questions. Can we sit down? Or, if I'm at the computer, like charting and asking, having that other person sit there next to them. And honestly, sometimes even offer a hand to hold. Like, or if
Mm-hmm.
you see that the patient's getting emotional, having someone there. And that is an advocate. So instead of making it sexy, right? Because I know that's the other thing too, is if you, the first time you have to ask these questions or you have to do this, bringing emotional support. And that's what an advocate is. And sometimes having another nurse be emotional support for both of you is appropriate. And,
Mm-hmm.
but doing it the right way. There's nothing fun or sexy or exciting about it. And a lot of times there's drugs or alcohol involved. So you have to check your personal beliefs at the door. I treat this a lot like when we ask them, do you want smoking cessation? And they say no. And we give them a nicotine patch. Or do you want help, to stop drinking? And they say no. And they get their order for their beer or wine. With their abusive relationships are no different. We, and it's
Mm-hmm.
the same with drugs. Like, do you want help getting off of your fentanyl or whatever? If they say no, we can't give you fentanyl necessarily, like dirty street fentanyl while you're in the hospital, but we're going to give
Right.
you methadone or Suboxone or something to keep you from withdrawals until you check out. So, when when you're asking these emotional questions, offering emotional support, having a social worker, an advocate, a therapist, or somebody, guys, I know that y'all are overworked and underpaid as nurses. We work in a very high stress, and I loved Krista's work at Move and talking about PTSD in nurses and vicarious trauma. And I was like, oh, yes,
Mm-hmm.
speak to my soul.
Which, by the way, is the Healing Trauma and the Birth Professional class online. So it is
Yes.
available for everyone. It's $30. It's the best self-care investment
Yes.
you could make on understanding all of that, because and honestly, like, supporting you in maintaining your work. So FYI, it
Yes.
is available. Mm-hmm.
You need to be ready for when they do answer the question and give you the tea,
Mm,
because if they're ready, like you're the person, they have chosen you, that is a moment and you don't want to squander it,
yeah,
and you don't want to make a mockery of them, because it's an honor. They have chosen you
yeah.
and they are looking to you for help, and this is your moment. This is your moment
Mm-hmm.
to actually make a difference. This
Mm-hmm.
is your starfish. Reach out and pick her up, because there she is.
Tell us about your research.
So when I started my PhD process, I was looking at so many different things. The first thing I wanted to do, and they were like, absolutely not, is I wanted to do qualitative research talking to sexual assault survivors that had delivered a baby afterwards, either from a consensual partner or somewhere down the road. And I wanted to look at the words used by labor and delivery healthcare professionals
Mm,
that re-traumatized sexual assault victims. So
okay.
I really want to, so my next project is going to be to dive into that. But they were like, no, that is a protected group. You cannot talk to sexual assault survivors about going through labor and delivery. Um, you
Interesting.
know,
Huh.
yeah, it was, I work with I love my school, very conservative school, IRB process.
Yeah.
And it's to protect people, right?
Yeah, for sure. For sure. We love that.
So I was like, I want to do something in this realm that I love, like, and I want to do something that's going to make a difference. So, what is something that we're not talking about? Everybody's talking about strangulation and near fatal strangulation, and there's great, great research. There are some wonderful healthcare professionals out there that, Dr. Bill Smock, Diana Fagno, there's just so many that are doing really good work. And there's protocols, there's checklists, there's assessments, all this. Okay, this is all the tools are there. How do I get them to the nurses, right?
Yeah.
What do nurses know? Where are the nurses at in all this? And
Yeah.
so I started going down the rabbit hole of like, well, okay, I know all of this exists. And, like when I got your reaction at Move, this plethora, smorgasbord of stuff is here, but nurses don't, it's not even that they don't have access. They don't know it's there. We're not training nurses. We always talk about that gap between evidence-based research and getting it into practice. And I'm like, this can't wait. This can't
Mm-hmm.
wait.
Mm-hmm.
So I decided to do a survey of nurses to ask them how to rate their own self efficacy. So, for all of the steps of the strangulation exam, how well do they think they can perform these steps?
Mm.
So, it's everything from the actual like asking the questions to performing the individual functions, like measuring, different things, or, do you know how to look for petechiae or where to look for petechiae? Like, can you perform these steps? Oddly enough, like I'm still doing synthesis on the data, right? The nurses in general rated their ability to perform like the assessment tasks fairly high. Where I saw things starting to waver is collaborative care or things outside of what would be like, okay, I can do the head to toe assessment, I can
Yeah.
assess what's abnormal. What do I do now?
Totally. Yep.
And I thought that that was really interesting because And it was funny you mentioned the cranial nerves. That's also where people started falling off a little bit, and they were like, "Ooh,"
Yeah.
and keep in mind, like, I'm specifically asking nurses in labor and delivery, OBER or OBED, and labor triage, and so, my ER nurses are like, "Yeah, I got cranial
Right. Or
nerves,
like if you've
great,"
ever spent time in a neuro unit or ICU.
Yeah,
Yeah.
but asking labor nurses, like, can you do a check, and concisely document using exact words of, the patient in near fatal strangulation? And like 49% of nurses were like, yes, I can document using the exact patient's words. And I'm like, really? Do you know how hard that is? Like, and I was very curious about that one because that's one of the hardest tasks for me as a sexual assault nurse is, I'm not a stenographer. So when I'm having to type down their story in their exact words, that's really
Mhm.
difficult. And I was like, huh, okay. So I was really
Mm.
surprised. But the nursing pieces, like, part of me, the inside was like, yeah, go nurses, go. Like, we're comfortable doing assessments. Some of the things, like the delayed complications, the anoxic brain injury, people started falling off. So now that I have all this data and now I have all this in place, the goal is so I created a standardized tool, that, and now I have the data behind the tool to say this is significant, it's statistically relevant. The tool will be made for free after the dissertation is done going through the publishing process, which is happening right now.
Yay.
So, yep.
Amazing.
Um, and then the idea is it would go to like an educator in a unit. It's just a few questions, nurses score themselves, and it allows for the unit educators to go, okay, this right here is what I need to do more education on. Maybe it's documentation, maybe it's documenting injuries, maybe it's symptom recognition. But that means we can now do targeted education within the units on what we need. And some
Hmm.
of it too is just, do you know where to find the policy?
Yeah.
And I know, like, everybody's like, when Jaco gets here and they ask you, make sure you know the magical binder of policies is
Yeah.
here or there, or it's on policy tech or whatever they use. But
Yeah.
this is important, right? So that was the goal. So, from the early bits of crunching the data, I have a statistically significant tool, and it's a tool that can be used, and it will be made free and available to all healthcare workers.
So I have to say this especially because it's now working more with hospital leaders and researchers and like not like I work so much with staff nurses too, but I have way more exposure now in this role than I ever did in the hospital to like other subspecialties of nursing and medicine. And so I want to just say that like these tools are essential to us continuing to move the dial. If ever, for instance, I'm thinking about HCAPS because HCAPS is like a survey, right? I don't know if you would call it
Hmm.
a tool,
Yep.
but basically, like you would give an HCAPS survey, and then that would give an HCAPS number to for
Yep.
related to patient satisfaction for patients. And so when I'm talking about this data with hospital leaders, I talk about how HCAPS doesn't actually give us the next step. It tells us where we're not doing so hot and where we're doing great in the realm of patient satisfaction, but it doesn't actually specifically rate or give suggestions for or identify the issues in your unit. And so literally and luckily like I had this data, but it stands out to me because on my first call with hospital leaders, I had the Maury Mothers
Hmm.
on something index and then the childbirth experience questionnaire as
Yep.
vetted tools that actually do give that information. And
Yes.
so when we actually do use a tool like this, we
Yep.
find that these things lead to better patient satisfaction than just an HCAPS. And HCAPS is like a check-in point, but if you're actually wanting to know what to do about it or what actually contributes, these are vetted tools. And I remember, like, when I mentioned this Maury and Child CEQ, like people were taking notes of like, oh, and then I had another nursing statistic about nursing retention. And the one question that I had on this entire call, which this was not the point of the call, what
Mm-hmm.
tool did they use to measure nurse satisfaction? And I was like, let me get that for you. And I knew I'd read it, but I just didn't have it on my slides. And so this, like from a pullback standpoint, because I did not get this until I was doing my own synthesis of research and reading these articles
Mm-hmm.
constantly and like deep in it, that these tools are the gateway to evidence-based practice. That like when, you know, and I think it's easy to be like, oh, you put together a survey, but like this survey has so much potential for actually being something that like gives data about a unit's
Yeah.
practices and your nurses that then can become actionable. So I
Yeah.
like I think it's so exciting and so cool, and also like for all of us nurses to know that like nursing should and can be a part of research, that can be a part
Yeah.
of leading change in this way. And like this is the way, I mean, we know data is the thing that moves the dial, and medicine, you know, like nothing happens without data. We love our data.
Right. And here's the thing, once you have the data, what do you do with it, right? So if I were to like just show up to your hospital and I'm like, hey, we got to do this, right? And everybody's like, okay, but why? Right. And
Yes.
I can show you the why. And then, but then there's questions about implementation and education. And then because a lot of this, like I said, nurses have these skills. These are not
Yeah.
new skills. It's just a matter of showing them how to appropriately apply these skills,
Yeah.
right? And I think every hospital is going to have different needs. Every hospital's got its own thing. So this tool would allow hospitals to identify the needs of their nurses and their educational stance, like where is everybody at, and do some more targeted things. The other thing too is like, and as an educator, I can't just sit and talk for 3 hours and expect you to absorb all of it, right?
Mm-hmm.
Being able to provide good bite size interactive material so
Mm-hmm.
that we can retain this is how I'm going to move things from your short term to your long term memory. And it's going to stick and it's going to become rote and part of your practice. And these are the things that are going to change healthcare. And that, my dear, is how we're going to move that number. I
Mm-hmm.
I don't want homicide to be the number one anymore. Like
Yeah.
that's how we're going to change this.
Mm-hmm. Beyond that, what's your hope for the future?
Truly, what I hope for the future is that when my daughter, if she were to decide, because she tells me she wants to have a kid all the time, I don't want to have to worry.
Mm-hmm.
I want her to go into a healthy, safe, sound environment with good, competent nurses and a hospital that supports them. And so she's supported. And I like that's what I want. Like I want us all to be able to go get health care in, a good way.
Mm-hmm.
So not everything in the world is good. I'm not going to fix the world. I'm not going to save the world, but I'm looking to save a couple starfishes along the way.
If you were to ask the nurses listening to do one thing in their practice that, like, after listening to this, now do this instead or add this, what do you feel like that would be?
Ask that intimate partner violence question and like ask it in a way that your patient knows that you mean it and truly care.
Mm-hmm. Thank you for being here and for sharing. There's so much more that we could talk about. And so if you are, I'm going to not say too much, but if you are like really into this and want more, need more, et cetera, there's a list that I'm going to strongly encourage you to add yourself to in the show notes down below. And that will be obvious just to be notified of future related things. And so
Yeah.
check that out down below. And then also check out the show notes down below. And I think for all of us, I want to thank you from this community for the work that you're doing and for bringing this to light and being so open and excited to share with us. And I think this community is like, there's no better community than the bundle birth nurses community, because these are the nurses who are out there like, okay, I'm going to go read it and I'm going to go do the thing and I'm going to do my best. And you don't have to do it perfectly, but I'm going to apply myself and at bare minimum ask that question, let alone learn about a safety plan. Or maybe you also are like sparked to be like, wait, I could do this too, and I have a passion for it. That like looking into forensic nursing, etc., which is where we are coming back for one more episode where we are going to talk about forensic nursing, specifically related to sane nurses and dealing with sexual assault. I'm going to ask some tips on things to say, things not to say, your approach, what that means. And so make sure you subscribe down below. If you want more from us, you can head to bundlebirthnurses.com, follow us on Instagram, or subscribe to our educational newsletter. And then now it's your turn to take what you learned today, apply it to your life, and then on your next shift, when you are doing your intake questions, pause at the door prior to meeting your patient and commit to learning how to approach the question, quote unquote, do you feel safe at home, in a way that is sensitive, and it provides an environment where a patient could disclose to you what's going on after you've built rapport. We'll see you next time.